Welcome to Doctors of Medicine. Welcome to our series. So today we are going to talk about the inguinal canal. The inguinal canal. So here, this is the diagram that we have that shows the position of the inguinal canal. It is found on the inferior part of our abdominal cavity. Right. So the inguinal canal embryologically is formed due to the descending of the testes toward the scrotum. Right. So we are going to have what we call the processus vaginalis. That is going to form a canal embryologically, piercing some important abdominal layers. So it will first pierce what we call the transversalis fascia. Remember, the transversalis fascia, it is a deep investing fascia that covers the abdominal, the transversalis, internally the transversalis abdominis. So the processus vaginalis is going to pierce the transversalis fascia, and it's going to form what we call an ovoid defect or an ovoid opening, what we call the deep inguinal ring. So this will be our opening of the inguinal canal. Where is the deep inguinal ring found? Remember here we have what we call the inguinal ligament that forms the inferior part of the hexagonal shape of the anterolateral abdominal wall. So the inguinal ligament, it extends from the anterior superior iliac spine into the pubic tubercle. So between or midway or halfway, we are going to find superiorly the deep inguinal ring. That is 0.5 inches or 1.3 centimeters. So the deep inguinal ring, it is an opening in the transversalis fascia. So the processus vaginalis will continue to pierce. It's going to pierce the internal oblique muscle. It's going to pierce the external oblique aponeurosis. When it pierces the external oblique aponeurosis, it's going to form what we call a triangular defect in the external oblique aponeurosis. That is going to give us the superficial inguinal ring. The superficial inguinal ring is found superior medial to the pubic tubercle. What we have on the superior inguinal ring, it is not oval shape, but it is triangular shape. So we are going to find two limbs of crura that are going to form the superficial inguinal ring, in lateral crura and the medial crura. These are just fibers of the aponeurosis of the external oblique. So the medial crura is going to attach the pubic crest, while the lateral crura is going to attach the pubic tubercle. Right. So we have important structures that pass through the inguinal canal. In male, the main content of the inguinal canal is the spermatic cord, whereby in female, the main content is what? Is the round ligament of the uterus. So you're going to find certain contents that are going to pass through the inguinal canal. What is the length of the inguinal canal? The inguinal canal is just 4 centimeters long. 4 centimeters long. So it has important borders. 4 borders that you need to take note of. We have the anterior border, the posterior border, we have the roof, and we have the floor. What we find on the anterior border? So I'm going to divide the anterior border into 3. Lateral, middle, and medial. Lateral, what do we find at the lateral? Remember, we also have a muscle that is called internal oblique that originates 2/3, the lateral 2/3 of the inguinal ligament. So in the lateral aspect of the anterior border of the inguinal canal, we are going to have fibers, right, of the internal oblique that will be reinforcing the deep inguinal ring. So at the middle part of the anterior border, we are going to have the external oblique aponeurosis, and then at the medial part of the anterior border, we are also going to have the fibers of the aponeurosis of the external oblique, forming the superficial inguinal ring. So that's the anterior border. The posterior border now, we are going to have, like I said, the deep inguinal ring. So we are meaning to say the deep inguinal ring is formed as an ovoid defect through the transversalis fascia. So posteriorly, we are going to have the transversalis fascia, lateral, middle. But now, at the medial now, we are going to have the transversalis fascia being reinforced by what we call a conjoint tendon. A conjoint tendon, some other sources, they say it's called inguinal fibers. So we're going to have fibers of the aponeurosis of the internal oblique and the transversalis abdominis. They are going to join, and posteriorly, as they are going to attach the pubic crest, they are going to join posteriorly and reinforce the what? The superficial inguinal ring. To the roof, we have structures that are crossing over. Two structures that are big, that are the transversalis abdominis muscle as well as the internal oblique muscle. So the internal oblique muscle is a bit lower than the transversalis abdominis muscle. So the internal oblique muscle has a direct communication or contact with the contents of the inguinal canal. So that is the roof. What do we have on the floor? The floor of the inguinal canal is made by the inguinal ligament. The inguinal ligament is going to extend medially, and then at the medial aspect is going to form fibers that are going to fuse on what we call the pectinal line. These are called lacunar fibers. So medially at the floor we have lacunar fibers, and then laterally at the floor we have the inguinal ligament. So these are the borders of the inguinal canal. Okay, so guys, let's talk about the contents of the inguinal canal. So the main content in male, we have the spermatic cord. So the spermatic cord is going to contain certain neurons, certain nerves, certain artery, certain veins, and the vas deferens. So we are also going to have the ilioinguinal nerve. But you need to take note of this. The ilioinguinal nerve, that is a nerve coming from the lumbar vertebral 1. It's a termination of the A1 coming from the lumbar plexus. So the ilioinguinal nerve, it does not pass through the deep inguinal ring, but rather it is going to transect the canal, whereby when it passes or pierces through the external oblique aponeurosis, the internal oblique muscle, and the transversalis abdominis. So it's going to enter the inguinal canal, but without passing through the deep inguinal ring. So here is the cross section of the spermatic cord. So in the spermatic cord, we are going to have what we call testicular artery. This one. Testicular artery, we are going to talk about later in our next lecture series about the abdominal aorta. So at level L2, just 1 centimeter below the branches of below the renal arteries, we are going to give what we call a gonadial artery, but in male it's going to call the testicular artery. The testicular artery is going to move retroperitoneally, pass anterior to the ureters, pass anterior to the common iliac arteries, and then it's going to enter the inguinal canal through what? The deep inguinal ring. Pass through the inguinal canal, pass through the superficial inguinal ring, and then it's going to supply the epididymis as well as the testes. That is the testicular artery. And then around the testicular artery, we are going to have what we call the pampiniform venous plexus. So we are having the testes, we are having the epididymis. So we are going to have 8 to 10 branches or tributaries of this pampiniform venous plexus that will be surrounding the testicular artery. Why? Because we want to maintain the temperature of the testis below 3 degrees to 1 degree of the normal body temperature. So you're going to find the pambidiform venous plexus, it will surround the testicular artery so that there will be heat exchange. And when we are maintaining the temperature in the testis for spermatogenesis. So the pambidiform venous plexus here, you can see here, this our testicular artery is surrounded by 8 to 12 veins. So as these veins reach the deep inguinal ring, they are gonna fuse and they are gonna form what we call testicular vein. So to the right, we are gonna have the testicular vein draining directly in the inferior vena cava. And then to the left, we are gonna have the testicular vein draining indirectly to the inferior vena cava via the left renal vein. So that's the pambidiform venous plexus. We are also gonna have other arteries that will be supplying the contents of the spermatic cord. Remember, we said that we have what we call the vas deferens. The vas deferens is about 45 centimeters long. It comes from the tail of the epididymis, and then it goes or pass through the spermatic cord and it goes behind the bladder and form the ejaculatory tract. So the venous deferens is supplied by what we call the venous deferens artery, which is a branch of the inferior vesical artery. We are also going to have the spermatic fascia. I'm going to talk about spermatic I'm going to talk about the spermatic fascia. We are going to have the spermatic fascia, what we call this cremasteric fascia. So the cremasteric fascia is also going to be supplied by what we call the cremasteric artery, which is a branch of the inferior epigastric artery. So these are the arteries that we have: the testicular artery, the cremasteric artery, as well as the vas deferens artery. So in the spermatic cord, we are also going to find lymph vessels there, lymphatic vessels. These lymphatic vessels, mainly, they will be draining contents coming from the testes. Remember, our testis, hemorrhagically, it originated in the abdomen. So the lymphatic drainage is gonna drain into the abdomen. So the testis lymph nodes, the efferent vessels, they are gonna drain in the pre-aortic nodes, or it's gonna drain in the lumbar nodes. So these vessels that you see, they are going to drain. Alright, so let's talk about the nerve, right? The nerves that we find within the spermatic cord, right? So we also have sympathetic nerves that will be supplying the testes and other related structures. But one of the most important nerves that we need to take note of is what we call the genital branch of the genitofemoral nerve. So if you are to go to the lumbar plexus, we are going to find that there are fibers that are going to come from L1, the fibers that are going to come from L2, that are going to emerge and form this the genitofemoral nerve. Then the genitofemoral nerve around the deep inguinal ring is going to split into two, or give two terminal branches, what we call a femoral nerve and the genital nerve. So what you find within the spermatic cord is the genital femoral nerve. So the genital femoral nerve is going to supply contents of the stomach, as well as a part of the epididymis. And we're going to find, we also need to take note of this, that the genital femoral nerve, right, it's going to give fibers that are going to supply the superior medial aspect of the thigh. the superior medial aspect of the thigh. So meaning to say, if there's what we call cremasteric reflex. So this genitofemoral nerve, it mainly supplies what we call the cremasteric muscle that is within the cremasteric fascia, which is responsible for retracting the testes when the body or when the temperature around the scrotum is high, is low. So you're going to find the genitofemoral nerve supplying the superior medial aspect of the thigh. That if postnatally, if that portion is going to be strong, you're going to have a reflex of the testes that is at that side rising, right? That is what we call the cremasteric reflex. And it's also used to check what we call hyperactiveness of the spermatic cord around L1 and L2. Since we said the genitofemoral nerve originates from L1 and L2. So it's important for cremasteric reflex, right? Then another content of the spermatic cord, we're going to have the vestige of the processus vaginalis. So remember, we said embryologically we are going to have the processus vaginalis piercing those layers. So it's gonna cut off. It's gonna be cut off. Where we're gonna separate the process, the parietal peritoneum of the abdominal cavity and the parietal peritoneum in the testes. But the parietal peritoneum in the testes will later form what's called the tunica vaginalis. We're going to have the visceral layer of the tunica vaginalis surrounding the testes, and then we're going to have the parietal layer of the tunica vaginalis. So it's just like a mirror of the peritoneum in the abdomen, in the abdominal cavity. So these are the contents of the spermatic cord, right? So let's just go for a summary. So we said we have the testicular artery, we have the pumbiform venous plexus surrounding the testicular artery. We have the lymph nodes. These will be draining the testes. They're going to drain via the lumbar nodes and the pre-aortic nodes. We're going to have the vas deferens coming from the epididymis, going to form what's called the ejaculatory tract. We're going to have the arteries of the vas deferens, which is a branch of the inferior vesical artery. We're going to have the cremasteric artery, that is a branch of the inferior epigastric artery. Yes. And we are going to have the genitofemoral nerve. And we also have some other autonomic nerves that will be also passing through the spermatic cord. So this is the spermatic cord, and you need to know it. Okay, so let us talk about the testes, right? Let's talk about the testes, right? So you need to take note of this, that the left testis is a bit inferior to the right. The reason being that the right testis, it will descend later into the scrotum, and after the left, right? So the testis, mainly we're going to talk about the covering of the testes, because the coverings are the ones that that communicates with the layers of the abdomen, right? So we're going to have the skin, which is a wrinkled, pigmented, right? And then from the skin, we are going to have what's called the ductus fascia. And then from the ductus fascia, we're going to have the ductus muscle. So the ductus muscle, remember we have what's called the cambus fascia, which is a part of the superficial fascia. So as it descends in the layers of the scrotum, it's going to be replaced by what's called a ductus muscle. Take note of this. Ductus muscle is a smooth muscle, which means it is supplied by autonomic nervous system. We also have what's called the callus fascia. So remember, the superficial fascia is this cambus fascia and membranous fascia, which is the scapus fascia. So the cambus fascia is going to be replaced, forming the ductus muscle, which I said is a smooth muscle. Then the membranous layer, which is the scapus fascia, is going to extend as callus fascia. So the callus fascia will be deep to the ductus muscle. So now, after all this being said, we are going to enter into the lining of the spermatic cord, starting with the external spermatic fascia, which we said is an extension coming from the superficial inguinal ring. And then we're going to have the cremasteric fascia. The cremasteric fascia will contain cremasteric muscle. So this cremasteric muscle is the one that we said is responsible for producing producing cremasteric reflex. So the cremasteric muscle is skeletal muscle. It is striated, meaning it receives somatic nervous supply. Take note of that. So we are going to have the external fascia, the cremasteric fascia, and then we enter into the internal spermatic fascia, which is a continuation, remember, of the transversalis fascia at the deep inguinal ring. And then deep to the internal spermatic fascia, we are going to have the parietal layer of the tunica vaginalis. So remember, the testis is not directly in contact with these layers, but there is a space, right? A space that is filled with fluid. So we're going to have the parietal layer of the tunica vaginalis, and then we are going to have the visceral layer of the tunica vaginalis that will be in contact with the testis. But take note of this, the visceral layer of the tunica vaginalis does not completely surround the testis. Remember, the testis, there's a portion where it attaches to posteriorly to the epididymis. So that portion has no visceral layer of the tunica vaginalis. Right. So these are the layers that you find when you are dissecting the testis. Right. So we're also going to have, we said we have the visceral layer of the tunica vaginalis. We're going to have what we call tunica albuginea. The tunica albuginea is just a connective tissue that is going to form septors in the testis, that is going to divide the testis into lobes. Remember, in the testis we have the seminiferous tubules that are around about 250 meters in length. So they are into lobes. Remember, these are the site. This is the site where spermatogenesis takes place. So from the seminiferous tubules, we're going to have tubules that we call straight tubules that are going to form the reed testis. And then from the reed testis, we're going to have efferent ductus. From the efferent ductus, we're going to have the epididymis. So we're in the epididymis, we're going to have convoluted tubules that are going to form the epididymis. The epididymis, if it is stretched gross anatomically, it's going to be have a length around 5 to 6 meters. Right. So the epididymis, we have a body, we have a head, we have a body, and we have a tail. As we move from the head, body, and tail, it tapers, right? Because at the tail, that's where it's gonna attach the vas deferens. The vas deferens, we mentioned that it's 45 centimeters, past the spermatic cord, superficial, deep, inguinal canal, and then it forms the ejaculating duct, right? Ejaculating tract, right? So that is the testis. What you need to take note of is the right. What are problems, or let me say the conditions that are associated with the testis? We're gonna find that quickly. Since we say that in the spermatic cord we have the pambiform venous plexus. And then we said it's going to form testicular veins. Right testicular vein draining into the inferior vena cava. Take note of this. The right testicular vein, it drains into a low pressure zone. Because the inferior vena cava is a low pressure zone. But now the left testicular vein, it drains into the left renal vein. So in conditions where there is malignant or cancer in the left kidney, you're going to find some of the cancer is going to cause distension. The tumor is going to cause distension of the renal vein, causing pressure or hypertension in the pumping-form venous plexus that we call varicose, right? So the varicose is more common to the left than the right. The reason being that the testicular vein of the left drains into a high pressure zone, right? So that is one of the most important things that you need to take note of when we are talking about the testes. Thank you. So let us continue. Okay, so let's talk about herniation, right? Herniation. I remember I mentioned that we have direct herniation and indirect herniation. So the one that is associated with the inguinal canal, it's indirect herniation. Why? Because the inguinal canal, it's oblique. It's oblique, right? So you're going to find that you're going to have the deep inguinal ring here, the superficial inguinal ring here. So there is no complete, let me say, communication or direct communication between the deep inguinal ring and the superficial inguinal ring. So it is oblique. So that's why we say it is indirect herniation. So we have what you call direct herniation. As you can see here, these vessels, these are inferior epigastric vessels. They run in the lateral embryonic fold, right? And then medial to the inferior epigastric vessels, we are going to have what we call the medial umbilical fossa. At the medial umbilical fossa, we're going to have what we call the Hazelbeck's triangle or the inguinal triangle. I think we mentioned it that the inguinal triangle has three borders, the medial border being accompanied by the lateral edge of the rectus abdominis, the inferior border being accompanied by the inguinal ligament, and then the lateral border, the lateral border being accompanied by the inferior epigastric vessels, then the inferior border being accompanied by the inguinal ligament. So the triangle, right, it's a site for what we call direct herniation. What are we talking about when we are saying herniation? What is herniation, right? So remember, in the abdomen there is high pressure. There is high pressure. The contents, the organs, the viscera, they are into a tight space. So whenever they find an opportunity of weakness, they are going to protrude. The peritoneum, mainly the parietal peritoneum, and the part of the viscera is going to protrude through the layers. So when we talk about herniation, we are talking about the parietal peritoneum as well as viscera, mainly the small intestines, protruding through the walls, the abdominal, the layers in the abdominal wall. So the direct hernia is medial to the inferior epigastric vessels. Medial. Then indirect hernia, since we said it occurs in the inguinal ring, in the inguinal canal, which means it is lateral to the inferior epigastric arteries, right, or vessels, right? So this is the main difference between direct and indirect. Direct, medial, indirect, lateral, right? So direct hernia, it is less common than indirect hernia. So you need to take note of this, that like I said, about 75% of abdominal herniation occurs around the inguinal canal. So indirect hernia occurs more than 2/3 than direct hernia, right? So indirect hernia, it occurs mainly in male. About 86% will be male, and then the remaining will be in female. The reason being that in male we have the spermatic cord. The spermatic cord, the descending of the testes, will make the diameter of the inguinal canal in male greater than in female. So you're going to find herniation more in male than in female, right? And then indirect herniation in male of the right is more common than of the left in male. Why? Because since we said the left testis is inferior to the right testis. The reason being that the right testis, it will descend later than the left. So you're going to find herniation being more common to the right than the left. So that is everything that I have about direct and indirect hernia. Thank you so much. See you in our next lecture series.